this week, what we're doing is we're going to talk a little bit about learner assessment. And the purpose of this was sort of twofold. Like one was, as I was going through, I was realizing that it could be because when the course was first developed, people attended it in blocks. And so I pretty much had some guarantee that people would see most of the content, which is different than this, where people do have to come and go. And the second thing is I realized with the academic year transition, there may be people who have to transition in and out of the course. So my thought process was sort of making sure that if we kind of intertwine the content rather than going through it in sequential blocks, people will get some exposure to all of it. So this week we'll look at learner assessment. It also works because I do think it comes back to questions that we've grappled with actually throughout the course, including in the leadership block, but also ideas that came up in the scholarship block. So it's a nice way to weave it all together. We'll go ahead and skip the icebreaker for this week since we kind of got to catch up a little bit in the first few minutes of the session. And as always, we'll do a reminder of what we did last time. So for those of you who are here, you might remember the initial part of our session focused on educator dilemmas. And what our group was really grappling with was, oops, this is not right. Our group was really grappling with writing letters of recommendation and with difficulties around learner handoffs. And then what we did subsequently is we covered the problem gap hook heuristic. So we talked about writing an academic paper as the equivalent of joining a conversation at a party after eavesdropping. And so the eavesdrop is doing your literature review. And then in order to enter the conversation, this author made an analogy that you need to do three things. You need to tell someone the problem. So what is the problem that you're discussing? And highlighted that this was related to, but distinct from the topic under study, gave the example of leadership and collaboration, which we could say the topic we're studying is either of those, but the problem was that those ideas are in tension and are rarely studied together. And then you need to establish a gap. So what is not known about this problem? And this is related to, but distinct from your purpose and aim statement or your stated research questions. So again, in the example, it would have been that despite leadership and collaboration both being competencies, they are often not put into dialogue with one another. And then the hook is why should we care to learn about what we don't know about this problem? And embedded in that is why should we care to learn about it now? Again, in the worked example that we had from the paper, the hook was that this is now a required competency in the CanMed system. And so this is going to become relevant for programs to maintain accreditation. What we're going to transition to this week is talking a little bit about other ideas that can exist in tension with each other in medicine and not be in dialogue. And so we'll kind of, in a very loose way, have a connection to the problem gap hooks worked example. And so what we're going to set out to do today is to define evaluation and assessment. So these terms are sometimes used interchangeably, but when you go to search the literature, they have different meanings, and education specialists use them to mean different things. So this is a chance for us to learn to talk the talk. We'll talk about concepts from assessment and specifically define formative and summative subtypes of assessment. And then we'll explore some tensions between two discourses in medical training, one that emphasizes diversity and one that emphasizes standardization. And we will use this to actually set us up to do an additional reading next week that's quite recent, that looks to bring a lot of different things together that we've looked at in this course. And then we'll list aspects of the current assessment practices in medical education that could contribute to the illusion that we're being objective when in fact we're approaching it still quite subjectively. So to start off, let's talk about some of the problems that exist in learner assessment. And so 3 of these are adapted from a talk that Karen Hauer gave at UCSF. Karen Hauer is one of the kind of leading thinkers about assessment in medical education. So the first issue that we have in assessment in med ed is reliability. So we often have insufficient data points, and this threatens our ability to determine if our assessments are reliable. the classic way to teach reliability is if you think about trying to aim for the bullseye of a target. What reliability is that each time you take a shot, you hit the same region of the bullseye. It doesn't mean you're hitting the center of it, but from one observation to another, for example, there's some degree of consistency in the measurement that you get. Another way to think about it would be like if you use a thermometer 10 times, it always gives you the same temperature. Whether or not that temperature is the right temperature is a different question. And that question is answered by validity. But this is also a problem in assessment. So we have insufficient evidence often to use assessments for making the decisions they're used to make. So an example of this would be the very long history of using step 1 and step 2 to make decisions around matching people to residency, despite there being a good body of evidence that we were not actually measuring people's ability to perform well as practicing physicians. And so that would be an example where the test was consistent, but we weren't actually hitting the bullseye we wanted to hit. And then we were still making decisions using that as the data source. And so this is another problem we have in medical education's learner assessment. The third problem involves how we affect the motivation of students. And this we can kind of label the impact on learning. So assessment practices can shift focus from learning to performing. This is not uncommon that when you go to measure something, people's behavior changes in response to the measurement. And then a fourth problem that I would add to this list would be a lack of a shared mental model. And so there really is not consensus on what we're looking for. And we're going to start to talk about that using this idea that there are these competing discourses within medical education. And so, as I said, we want to be able to talk about this with people who are expert in it. So let's go through a little bit of nomenclature. So typically when we talk about evaluation, what we're speaking about is programs. So if you search the literature for evaluation, what you'll end up with is things that look at curricula, educational interventions, behavioral interventions. So an evaluation is the inferences about the effectiveness of a program that typically we derive by defining, selecting, designing, collecting, analyzing, and interpreting information about process and or impact of a program. This is in contrast to assessment, which typically refers to looking at learners or students. So these would be inferences about the learning or development of students, again derived by defining, selecting, designing, collecting, analyzing, and interpreting information about development and or learning or amount of learning. So in situations where you get like a request to do a student evaluation, really in the education literature, we should redefine those as student assessments or learner assessments. Within that domain of assessment, so the attempt to infer something about a learner or a student, we often divide further into formative and summative assessment. Are these terms that people have heard of before? What have you been taught or what have you sought out about these terms?
I can start if you want. Like formative is an assessment for learning, they say. So it's something to help the student learn more. And summative is kind of, I want to say the word evaluation of what he learned or assessment of learning.
Great. Yeah, so that's awesome. So I think that does a really good job in giving us the big picture. So typically we think of formative assessment as promoting learning. It's often rooted in teaching. In a best case scenario, it's not strictly criterion-based or normative. So effort and progress both matter. The other thing that kind of comes up is that there being some variation in the assessment information can actually guide future learning. So it's still important that it's valid, that you're getting feedback, for example, on the thing that you want to get feedback on. But having a variety of different opinions can actually be helpful. Getting people's perspectives, even if they don't agree, is still useful in formative spaces. It is typically also considered more relational, and we do colloquially often call this feedback. I will say that even though in best practices it's not criterion based, I do feel like often, for example, if you've worked with someone for 3 or 4 days and you're halfway through your relationship with them, let's say you're on an inpatient ward and you ask for feedback, people struggle with this. Like, it is very difficult for people to compare you to your prior self. You'll often hear people say like, oh, you're way ahead of your level. That actually is like a normative and like somewhat summative statement, whereas a formative statement might say something unrelated to that, like I've noticed that you're really efficient at completing your notes. I've also noticed when we do histories together that your review of systems could be fleshed out to get even more positives and negatives. Even if it's a third-year student and the pertinent positives and the negatives are an advanced skill, a formative assessment really compares you to your old self and helps you move towards a future self. And that is different than summative assessment, as Tofik forecast for us. So summative assessments report achievement. They are rooted in assessing. They focus on progression against specific criteria. So what is the level of performance or competence that we would expect versus where you are now? Variation in assessment information in summative assessments represent error. So these have to be reliable, and that's because typically we're using them in order to make higher stakes decisions. So we care now about both reliability and validity. A wide variation in opinions on someone would be regarded as problematic, for example, if you were going to assign a clerkship grade. It is a bit more transactional than relational. It really is like, you did this, and now here's like the mark that you're going to receive because of that thing that you did. And then again, generally we think of this as high stakes assessment. So let's take kind of the boring creating a glossary part and set it aside. And now let's talk about something that I think is meatier and sort of interesting, which is tensions in assessment discourses. And so this is actually, I would say, probably like one of my, this is like a very nerdy thing, but if I had to pick like my 5 favorite papers in medical education, this is definitely on my list of like the top 5. And so I'm really glad we got a chance to look at it together. And what you might recall from the paper is that it puts forth that there are 2 competing discourses in medical education. And I will say that this particular paper is definitely written rooted in like the way that medicine is taught and practiced in the United States. It probably has global corollaries, but just to acknowledge the perspective that it was written from. And so what it talks about is that this discourse of diversity emphasizes respect for and value of individuals, students, and their unique life experiences, their educational backgrounds, their identities, like their gender, race, religion, ethnicity, socioeconomic status. We could add to this sexual orientation as well. And this is contrasted, and this shows up, I should say, in things like medical school admission policies, which are often very explicit that they're looking to put together a diverse set of leaders, for example. It initially started off as a moral discourse that like this is the right thing to do. And then it has evolved to sort of talk about how this has educational dividends for addressing health disparities. If we have a population of doctors that reflect the population they serve, all of us will be better at taking care of patients who are affected by disparities. I would say that like this discourse, I think there's actually now like a third movement, which would be talking about things like the minority tax, like you don't recruit a student to medical school for them to be a teacher to everybody else. So I think that this is undergoing ongoing evolution, but these are at least 2 big movements in this discourse that these authors back in 2013 were able to identify from the existing literature. And this is in contrast to the discourse of standardization, which emphasizes the importance of being uniform, consistent, that we need to have enough commonalities amongst trainees and physicians that we can do things like hand patients off to each other and be, for lack of a better term, somewhat interchangeable in terms of what we're able to do for our patients. And we see this in competency-based education, and which very explicitly, based on a Carnegie report from something like maybe 15 years ago, sought to say that students should meet specific standards, and that these need to be articulated in well-described core competencies. And we will come back to this again next week. So this is laying the groundwork for something exciting, a paper from about a month ago, or from about a year ago, excuse me. This paper goes on to kind of harken us back to that time that we talked about social constructionism, but now using it as a way to think about identity formation. And it reminds us that social constructionists would say identities are constructed and reconstructed throughout our lives using sociocultural resources that are available to us in our environments, and that students can adopt a variety of strategies for doing this identity construction work. And these strategies move across a continuum from adopting a standard identity to, or I should say, constructing a standard identity to constructing an alternative identity. And they define these. So they say a standard identity would be heavily influenced by pressure towards homogeneity. This would be an attempt to fit into the mold of medicine, kind of captured in the phrase, the well-trodden road is the only road. Adopting or constructing a standard identity would be typically regarded as easier for someone who already has a lot of the features of what historically was enshrined in medicine. So you might imagine that someone who has mostly majority identities may have less negotiation that they have to do to construct a standard identity in medicine. Conversely, students can construct alternative identities. And so these individuals tend to see the professional standard as being at odds with their other social identities. And the idea of adopting or constructing toward what is completely standard in medicine would feel like losing who they are. And these individuals therefore seek out ways to create an alternative identity that's actually based on being different from the norm. There are other literatures that talk about these as identities of non-participation, for example. This paper uses the term alternative identity, but other papers on identity construction use different nomenclature. And then there was a third option that's sort of in some senses in the middle of the continuum, which was a hybrid identity. So these are students who selectively borrow aspects from each of these discourses, and in doing that, construct an identity that allows them to mostly fit the standard while also retaining enough of themselves that they don't feel lost. And so I wanted us to use this paper to think through a few different questions. The first is, all of us are sort of fish in this water. So I was curious, in what ways, if any, have you noticed the tension between diversity and standardization as either a learner or as an educator? And then how do you navigate these tensions in assessment, and how do you guide your own mentees as they seek to construct their professional identities? So 3 big questions, but all which feel like they flow naturally out of the paper. Unless there's a pressing thought, let's transition into the second reading, which is also a really interesting thought piece on ideas relevant to learner assessment. And this paper was on the illusion of objectivity. And so I wanted to ask, to open this discussion, what we thought the key takeaways from this reading were, and what about it resonated with your experience or did not. And I think both your points are really well taken. There was within the last couple of years, there was like a systematic review of all the literature on assessing clinical reasoning skills. And one of the exam formats, to your point, that can do it when it's done well is these sort of like oral board-esque exams where you're really talking through your thought process. We get a lot more information. But the other point you make is equally important. For example, when you construct tests in like elementary and secondary school, there are people in that world who are big proponents that the questions should actually increase in difficulty, because if you sack someone's confidence in the first couple of questions, you actually never get them to their level of maximum performance. So I think that you're picking up on a really important nuance of how to construct good learner assessments. So that's awesome. It's a very powerful reflection. I'm keeping an eye on the clock, because I do have one other thing I want us to discuss, which is thinking to our local practices. So I see that we have some active things happening in the chat. If you have other reflections, feel free to drop them there. And I'm going to do a little bit of summarizing for us as we get ready to have the next discussion. So we touched on a lot of these things, but as a reminder, some of the things that came up in the paper were that core clerkship grading creates a lot of challenges, creates high stress environments, it can be interfering with learning if people are studying things that they may not see for years in practice instead of learning, for example, from direct patient care. And it does create inequities in the learning environment because of the way that these standardized tests perform differently across different groups of people. And this is particularly problematic because both students and faculty can succumb to this illusion that this is important because the process is objective. And the way that we tend to do this is if we have a quantitative rating, even if that quantitative rating was developed observationally through a very qualitative method, or maybe even better to say a subjective method, we treat those quantitative markers as if they accurately convey measures of the complexity of clinical performance, which they almost exclusively are unable to do, or almost not exclusively, almost always unable to do. And some of the key problems that this article raised that harken back to those big four problems at the start of our hour are that because of how complex the clinical activities we do are, it's really difficult to capture them in like a single word, like honors or pass. It's a distillation of so many things that would be better described in their richness. The data is flawed. We know that students report basically they're never directly observed by attendings, and yet attendings will certify in their assessments that they've observed students doing things that they've just never seen. And often that's because of proxies being used, like someone else, a very junior person who has less exposure and is less qualified, for example, to make the assessment, or using something like an oral presentation as a marker of how the history and physical went, even though they're not completely orthogonal, but quite orthogonal skills. And then the final problem being unequal opportunities. And they brought up this really interesting thing, which is maybe people who we think of as quick learners are privileged learners. So for example, individuals who have family members in medicine who could either get help on an oral presentation, or individuals who have just been around this milieu. Maybe they grew up like going to a parent's office or went to round in the hospital with a family member. They may actually be drawing on those sociocultural resources that were granted to them as privileges, and because of that, may have less of a difficult learning task in integrating. And so then we look at them and say, oh, they're picking it up so quickly, but in fact, what they're doing is drawing on prior experiences. So it may, in a very kind of interesting way, perpetuate some inequity. They put this table together, which we won't go through every single row of, but I liked that this article, which is a thought piece, did a really good job in this table of sort of saying, well, we're criticizing these things and we're imagining a future, but what would that future actually look like? And I think some of the things for me that stood out from this table are this row here, so clarity of expectations, which I do think in current practice remain opaque and confusing. Students often are wondering, like, well, what do they care about? I met with someone recently who's making the transition from medical school to residency, and one of the questions they had was like, well, how am I going to be assessed? And I think it speaks to the fact that it's so deeply ingrained during medical school, and so pressing a question that even in the transition to full clinical practice, this person felt prompted to ask, like, how is this going to work? And I think that it would be helpful if these were transparent and understandable. And competency-based medical education, to its credit, does seek to do that, to have descriptions that you can actually use to say this is what we're looking for. The other thing that I thought was really striking was this final row, which is the student's role in assessment, and transitioning them from being passively someone who's being observed and then had a decision made about them to a more active partner in their learning. And again, I think this is striking to me because of all the discussion we've had in prior sessions around the idea of the impact of assessment on things like whether or not you're self-directed in your learning. So lots of great things from this table to think through, but just wanted to highlight a couple of them. And that brings us to the sort of closing set of reflections, which is what ways, if any, does your institution's approach to assessment align with the author's proposals? And then how does the article change your perspective on your local practices, if at all? Yeah, absolutely. And I think that's a really great distillation of a bunch of the different themes from the discussion that we had today. And the flawed data, I think, really is such an important part of what this paper highlights, because it is so common for learners not to be really well known by their attendings. And I think harkening back to the beginning where we talked about formative and summative assessment, a better model probably would be where you work with someone for a really long time and their role is largely formative. It's just like, how do we make you better than you were 2 weeks ago, get you closer to being the best physician you can be? And then reserving these big summative assessments as markers of readiness to advance in some way for like stages of practice, for example. But what that would require us to do is for medical schools to really embrace the idea that like they do not exist to rank their students. They exist to teach them the fundamentals of what they need to be physicians. And I think we do get caught up in that idea of like, well, who's the top student? Who's going to go to such and such a program, do such and such a specialty? And until we like break ourselves free of those mental chains, we're going to continue to run into this problem where in some subtle and some very overt ways, the mission of the medical schools have become like, how do I identify my top 5% of the class? And that's not really aligned with the broader mission of creating a physician workforce in which everyone is excellent. So thanks everybody for like a really rich discussion. I'm excited about this learner assessment topic because I know it's one where there's a lot of contention and, as people have brought up, a lot of really cool contemporary thinking about how to make it better. So thank you everybody again for a wonderful week or an hour, I guess both. It was good to see you, and I'll see many of you in a couple weeks.